Great
Okay.
stuff. Okay, so I am just going to swipe right. And can you see those slides? Can't hear you.
Yeah, all good,
Oh, you
Lucy. No, I'm
can.
there.
Okay,
Yeah, yeah.
fine. All right, great. Thanks very much. Okay, well, thanks to you, those of you who are here, and to those people who hopefully will be listening to this at some other time. Part of the reason that I want to talk to everyone today is really to get a sense of where everyone is so that I can tell you what's happening in the UK and what's going to be happening in the UK in the future, and we can take the agenda of quality forwards. Now, one of the most important things that's happening now in comparison to a couple of years ago is that the quality agenda is really shifting in a quite fast moving way. And I know that members of the MSKPN who tried to get the equality agenda going with the CSP, a few years ago, would report back that the CSP really weren't interested. Now, at the moment, they really are interested, and every door I'm knocking on is opening, and people are saying, "Come on in and sit down and talk to me." So, what I'm going to talk to you about first of all is what's happening nationally and how you can get involved if you want to get involved. And boy, we really do want you to get involved. And then I'm going to show you a little bit about simplicity and our data collection, but most importantly, how we are using the data and how, if you employed it in your clinic or something similar, you could use that as well. So I would urge you all to have a look at the HKIP website, particularly for anyone who is wavering, considering, not thinking it's important, perhaps they can put it off. But anyone who's on the fence about whether they should go down the route of recording outcomes, PROMs, have a look at the Healthcare Quality Improvement Partnership. This effectively is the government's voice. So when the government in this country wants to know something about healthcare, whether that's at GP level, whether it's in specialist services, then they go straight to HKIP, and HKIP basically deliver clinical national audit programs, and they send recommendations back to the government. Their strapline is that they enable those who commission, deliver, and receive healthcare to measure and improve healthcare services. And the reason that we're very excited about this at the moment is that the next big thing is MSK outpatient physiotherapy. And we're at the stage now where the HKIP is meeting with Keele University and the CSP, and this is Sue Hayward Giles, who has the responsibility for quality and MSK outpatient physiotherapy at the CSP, and they're at the stage of scoping out what this would look like. Now, the background to this is very much really been pushed by Keele University. So Keele has had project money for short-term projects and ongoing projects, and they've really been lobbying HKIP to get a national audit program. So usually when HKIP does a national audit, they do it for 5 years. But they are very clear, and this is what is very good news. They are very clear that they want the audit to include independent medicine. It is not going to be an audit just on the NHS and on NHS outpatient physiotherapy. So I've been meeting with Physio First, and we've been talking about this, and we jointly with Physio First have a meeting with Keele at the end of the summer to scope out what it's going to look like, how we can help, and which clinics, if it's indeed is the number of clinics or however many, we can put forwards for this. And audit, down on the left-hand side is a little column that says, why bother? Well, there's a myriad of reasons why we should bother with audit. Ultimately, what we're looking for is all kinds of data and information tells us and leads us to personalized treatment plans for the patient. And understanding patients' responses so that we can make timely adjustments is really important to improving outcome. Regular analysis and effective measurement and ongoing measurement is what we want. It's not just a snapshot of time. And this is something that we need to take on board and we need to continue to do. Ultimately, we are validating treatment, which is evidence-based for specific conditions, which is why we're all collecting our ICD-11 codes and correlating happening to the patient outcome to the codes. Why are we doing this? Well, because cost effectiveness is very important for the government's point of view. Enhanced clinical decision making is very important from our point of view. And ultimately, we are validating our intervention, enhancing patient engagement, satisfaction, and ultimately its accountability. We know what's happening in NHS physiotherapy. We know it was an easy target. They were all redeployed during COVID. And we know that a lot of the departments just haven't recovered. But way before this, patients were not receiving hands-on physiotherapy. There are a lot of the places that I grew up in South London where patients are lucky if they get 3 sessions of physiotherapy, and ultimately it's one to assess and give exercises, one to monitor to exercise, and one to discharge. Very little hands-on and very little movement out of that. And what we really don't want is an audit just on that kind of physiotherapy. Okay, so there's just a screen. This is some data that the CSP sent to me in the autumn of last year, and highlighted in red is just the percentage of members of the CSP who work in independent service, so in clinics. I've seen it as low as 13.8, 14%, and as high as 26. So I reckon we can take a benchmark of about 20%, but we do know it's growing if we compared that to 20 years ago. And finally, we've got to remember the standards that the Healthcare Professions Council set in 2023, the change of standards, which basically standard number 11 is all about engaging in evidence-based practice. It's gathering and using information and having ongoing prems and proms to assess our quality management, assess our intervention, and to actually work with healthcare technologies to analyze this on our behalf. So there's a myriad of reasons why we should be doing this anyway and making it part of our routine clinical practice without this audit going on. So you may well know that actually the MSKPN actually evolved out of a need for a national audit to look at quality, or for more quality-driven analysis of our work. So what we need to know from a point of view of the MSKPN is actually what I can offer Keele, because Keele will be looking, and the 2 organisations that they will go to for clinics to participate in this audit is us and MSKPN. Now, we've done a recent questionnaire to all of the members of MSKPN, asking them about the data that they collect and whether they collect it electronically, whether they collect it automatically, whether they collect it manually. And we had a 53% response. So I can only assume that the 47% who didn't fill in the questionnaire are not gathering any data at all, or not gathering transferable data. And really what I need to question of those 57% and also those who did fill in the questionnaire is, are you set up for data collection, and is that data collection transferable? We know that 30% of our membership, or 30% of the 53% who filled it in, are using Simplicity. And that means that they are collecting it automatically. It's in a very reliable format, it's very transferable, and the clinics are set up to be part of any kind of national recording. The data showed from our questionnaire that there was a big range in people collecting data electronically. And what I don't know, with the exception of one clinic, is whether this electronic data is transferable, whether it's in a Google Doc, an Excel spreadsheet form, whether it's rigorous and will stand up to a bit of scientific vigor, i.e., whether we've got all outcomes, initial measures recorded pre-seeing the first assessment, and then at regular intervals and standardized regular intervals. Manual collection, our members told us that we ranged from 8% of people collecting PAS to 28% of people manually collecting pain. Now, again, I don't know whether that's people manually writing it in their notes and the notes not being extrapolated out into some format where it can be looked at 6 weeks later or 6 months later. And not collecting any data range from 60% from the past to 4% for pain. And, you know, those of us who are using Simplicity, we've all been in the not collecting data. We've all been in the trying to collect data without using something as formal as Simplicity. Either way, it's a very hard thing to do. So to those people who aren't there yet or aren't doing about it, aren't employing either companies or strategies to collect it themselves, please don't be frightened about moving forwards and moving away from that, because we've all been on that journey, and anything we can do to help, we would be very happy to do to help. If anyone is thinking of joining Simplicity, I would say please do it now. It's a great time to do it. We've got a lot of benchmarking data that I'm going to show you, and that data is just growing. And also, from the point of view of the national audit, the more people who we've got doing a similar data collection, the better. Okay, most popular reasons for not collecting data: time challenges, staff challenges, system limitations, and that's limitations of practice management. And what I would say to everyone here is that the energy involved in collecting data, the strategies that the clinic has to employ and get together so that we can get the maximum number of patients completing their questionnaires, their PREMs and their PROMs, takes just as much energy, whichever system you're employing. There's not going to be a magic practice management system that will do it all for you, churn it all out and present you with the data. You're still going to have to chase patients and employ strategies to persuade patients to actually complete and fill this in. And part of my role as well on behalf of MSKPN is talking to these practice management systems and also talking to Simplicity and asking them to engage or re-engage with the practice management systems to make it easier for our members to collect data. Essentially, we want it as easy as possible, as can be humanly possible. And I put, would the data be useful for you? Because I'm just going to show you a little bit of how we use the data that's come out of Simplicity in our practice here, just to give you some ideas of the variety of aspects that we use it for. So we have an email that goes out from the practice manager every Friday. It used to be called Friday Flash. It's now called Friday Bulletin. And on every week, Kira will extrapolate a different part of the data out of the Simplicity system and pop it into this. So on this date, it was keep up with your patient engagement. Our results have been great so far. Don't forget you can use the data like this on Simplicity's dashboard, and here's the data results for this quarter. So always very positive, and it keeps the physiotherapists engaged with what's happening. This was another one recently just showing how the Net Promoter Score had gone up, and that shows the Net Promoter Score over the 11 months that we've been doing it. Went down to 64 in the October to December quarter, and now it's back up around 71 again. So very much we use it to encourage and motivate the staff and keep them well informed. This one just shows the PASS score, and the PASS is one of my favorite outcomes. The PASS score simply stands, an acronym standing for the Patient Acceptable Symptom State. And it simply asks the question, are your symptoms in an acceptable state for you, given your lifestyle and everything that you have to do? The reason I like this is because it includes our neurological patients and women's health patients, and you don't have to be in pain to change it. And it's a simple binary yes, no. So represented in different ways. This is the easiest one to see, 6 weeks, 3 months. We've got quite high proportions of no, they're not in an acceptable state, to yes. And at 6 months, many more patients are moving from this area to the yes state. We also use it. This was one in February, I think. And this is Kira reminding everyone to put their ICD-9 codes in for the previous months and get into the habit of doing that. And then just looking at our global ratings scale. And then every week she tends to pick a patient statement for individual team members so that everyone gets a shout out from their patients. There's a box where patients can put in any other comments, and generally they put in very, very positive comments about the patients, which is really, sorry, about the physios, which is really nice to feed back for them. And this was something that I wasn't expecting when I started on this journey. I wasn't expecting the data to be so varied, so rich, and so helpful in all kinds of uses in the clinic. And so that's another one just showing the NPRS, the pain scales, and the difference in, on the left, it's baseline to 6 weeks, and then baseline to 12 weeks, and baseline to 6 months. So it shows the patients having a reduction in pain over that time. And again, we've got 3 more members of the team who are highlighted in the staff spotlight, which always is very positive. Clinically, you can always use the data. Now, this is a really interesting one. So this is Kira putting it again into the Friday bulletin and just looking at our journey of 188 lumbar spine patients and looking at some of the baseline scores. The GROC obviously doesn't start until this level. And the PASS score, we don't ask them if they're in an acceptable symptom state there, but seeing that are your symptoms in a more acceptable state, much more yes at 6 months after intervention, and your global rating of change is going up. Now, this is quite interesting here because I always expect a big improvement initially and then a tapering off. And we've got that in the MPRS scale, and then an improvement again between 3 and 6 months. So the thing that's quite useful here is to say, does your data actually correlate with what you would clinically expect? What does the research show in terms of how patients with this given condition get better? And once you've got a healthy year's worth of data, you can look at your knee patients, you can look at your back pain patients, your shoulder patients, your elbow patients. And in fact, next door, one of our consultant knee surgeons is in And so this morning I was just printing off this data for him. So within this, I was actually inputting the diagnostic codes looking at anterior knee pain. And this is anterior knee pain on the left, so that we could say, this is what we're doing with anterior knee pain to our surgeon. And within that, I could have searched just for knee pain, or I could have searched just for anterior cruciate ligament or ligament injury. And it can give us some quite nice data and show other members of the team that we are monitoring and recording and looking after their patients to the best of our ability. We're in the stage of this time of year in August, we get onto the 360 reviews. So all of the HR come out. And again, this is something that I didn't expect when I started on this journey. And so what Simplicity does is it provides you, there's a whole area called patient voice, and it gathers all of the data that the patients have put in, that they've written about you. And so you can get then a really lovely word cloud, Word document, whatever you wish to call it. And the way it works is the more people who say that it's great, we get a bigger shout out for great. If it's good, or email, I've only written it once or twice. And so I can look at this on 200 patients. I can look at it on it per person. I can look at it for a group of people. So I can look at it for all the spinal physios and see what it looks like in comparison to the knee physios or the sports physios. But the thing that I was quite surprised about this was when I first showed it to one of our members of the team and said, God, your patients love you. And she was quite interested because she was really pleased. But she said, you know, Lucy, you go to bed worrying about the one patient who you haven't done enough on, or you're really worried about, and you don't go to bed thinking about the 10 patients that you have really helped that day. So this is very nice thing to show them. So everyone's getting these printed off and fed back to them for their 360 reviews. And yeah, actually next week, one of our team members is leaving and changing profession. So he's no longer going to be a physiotherapist. And so we've printed off his, which says lots of lovely things, and framed it so he can put it in his loo, so that when he's really feeling fed up, about changing profession, he can remember what it's like to work with people. Other ways to use the data. Now, again, this is in the patient voice aspect, and we can search it down to just looking at things to do with quality of care, 100%. Outcome in this instance, and I can't remember what I called this up for, outcome is 60% negative, 20% neutral, and 20% positive. Staff physiotherapists, we've got 67%, 33. Communication and information. Now, this is our front of house team. And there was one set of data where Kira just looked at everything to do with the front of house, and it was all 100% for friendliness and welcome and knowledgeable and etc. So it's not just clinical data that we're looking at. This whole Simplicity has a big, rich use of data that you can use for your patients. Confidence and trust, condition related, respect, dignity, equality and accessibility, neutral, 100%. So there's a great variety of ways that you can use and interpret this data. So how do MSKPN use the data? Well, we've just started to benchmark. So we've had 8 organizations and now 7 organizations over the 12 months inputting data. And so we can now look much more reliably for, here we've got 12,000 bits of data. Here we've got, I think that says, 1,350. So we're pooling everything together from the various clinics to see how we're doing over the year. So this is the PSSFS baseline when patients are coming in for all of MSKPN in the different clinics, and then what they're like 3 months later. And we can see that there is a good improvement of 2.3. And we can see here in relation to area of the body part or condition, who's coming in with most pain and who's coming in with the least pain, and what the mean amount of, sorry, PFSS, of functional difficulty. So this is functional difficulty score, and what the mean is for the clinic. So with that, I can look at my data and say, oh, well, we've got patients coming in with much more significant pain. So perhaps we wouldn't expect our outcomes to be as good as the rest of the group. Or I might say, well, we've got people coming in with much lower levels of pain, which is probably why our outcomes are better than that of the rest of the group. So this is looking at the numerical pain rating scale in exactly the same, similar sort of way, 0 to 12 months, 12 weeks, and with the same format for area of the body. And again, we can look at this. We'll have more and more data with this, so we'll be able to drill it down much more specifically to clinical data and see how your clinic benchmarks is against the rest of MSKPN. So this is a call from me. What do I need? By the end of the summer, please, I need to know as much as I can about what everyone is doing. If you didn't fill in the questionnaire, please go back through, scroll back, fill in the questionnaire for me, or drop me an email, let me know what you're doing. If you want to have a chat with me, I'm really, really happy. I need to know if you can participate in whatever is coming up. And really let us know. Speak to Simplicity if you're interested in participating, or speak to any of the clinics who've been working with Simplicity. The questions you need to answer yourself if you are collecting data is, are you collecting it systematically? Can you transfer your data? And can you interpret your data? Those are the most important things. Okay, and this really is a work in progress. Good. Now, that's all I wanted to say. I'm going to go back, if I can, to the screen. Here we are. And let me know if there's any questions.
Lucy, I was just wondering, so obviously I've been immersed in the weeds of this for a long time as well, like yourself. I had discussions with Jonathan at Keele many years ago, back when I was having discussions alongside the CSP. So it is brilliant. You've done a great job in terms of, getting the engagement going there. One of the conversations that with Jonathan was around, which outcome measures to use and things. And obviously, being realistic, Keele have got a vested interest in using the MSK tool. They developed it. One of the reasons why we haven't gone with it is the cost, but also, patients just don't relate to it often, yeah. And it's very much a research tool as opposed to something that matters and is meaningful to patients. Have you got any sense of how they're going to try and look at this from a collective perspective? Because all the data that I've read, even with looking at the physiotherapy standards, and again, the physiotherapy standards were written by people at Keele who therefore had a vested interest in using the MSK tool as well. So I'm just interested to hear, we've gone down what I feel is a far more pragmatic approach, something that matters to patients in terms of goal-driven outcomes and things. I think it's got validity. I think we're demonstrating that in terms of its the way that we're all using it within our clinical practice. But I do have slight concerns that it's going to be completely swept or pushed out the way because the academics will just march right over it.
I think this is really interesting. To be honest, I don't think they've scoped it out to that level of detail yet. When I met with Roanna Burgess, she said that actually they were going to stop using that outcome measure and they were looking at the Bournemouth scores. But I didn't really delve into the depth of it because they were really just in the scope of, right, okay, because I was saying, right, what happens in terms of HKIP and you getting this piece of work, you're now tendering for it, which is what they're doing. Is there going to be any other vested interest, any other university tendering for this? She said no, that they're not. So they're fully expecting to get it. They think it'll be a minimum of a 5-year project once it's up and running. But certainly the outcomes haven't been agreed. It's not that far down the line yet. So she very much kind of, when I asked about that, brushed it aside, just saying that they were going to drop the one that they had been using before. So it could be in a state of flux. Yeah, it is interesting.
Because I mean, the article that she wrote about looking at outcome measures that she was lead author on. I mean, the interesting thing was the conclusions that they drew from it were you should use the MSK HQ outcome score. But when you actually read the it actually says that the PSFS is an equally valid outcome tool.
Yes.
I mean, I guess,
and that was the one she said to me that they probably would not be using. And please don't quote me on that, but that was what she told me. So, and she said they were going to look at Bournemouth instead. And I'm not familiar with the Bournemouth score. So, it will be interesting because particularly they are looking very much and get very excited about using NHS data going clinic to clinic data. So that it bypasses the clinicians, but they're going to have to set something up whereby it is, our data systems don't talk to the NHS. And so, there's going to be a lot of scoping out and logistical work to get this all going together, I think.
Yeah. And have they involved Matthew Carr and his team down in Suffolk?
Not that I think about. I did actually bring Matthew Carr up in the conversation to see whether she was going to take that forwards and say anything, but no, she didn't. And she didn't say that anyone else was tendering for it. She didn't think anybody else would have the scope. And she said that they actually have been doing the majority of the lobbying on this.
So, I mean, Matthew's now heading up the professional practice committee for the CSP.
Oh, right. Okay.
Yeah, might be worthwhile. Just actually flagging it up to him as well and things.
Yeah.
So I think the Bournemouth score, the Bournemouth score, I think, is stuff that was developed by the chiropractors down there. When we did the working group, they were very involved and engaged in in the whole process and things as well. So, but yeah, I mean, it's great that this is now becoming, so much more of a key aspect. I mean, we absolutely have to prove our value.
Yeah, I agree totally. I think it's quite interesting because also, when I spoke to Sarah Conroy, Karen had previously spoken to her a year or so ago and said that, she was very negative. By the time I've spoke to her, she was very positive about the need to demonstrate our worth. So I mean, all these doors are really opening at the moment, which is just fantastic. So I think we just need to jump on the bandwagon and see what we can do. And really importantly, we need to get involved. And we don't want this to just be NHS with a few extra private practices on the side. We want it, proper independent medicine where, we're used to proving our worth from a day-to-day point of view of asking our patients commercially to keep us going, but actually getting that down and showing the government what we can do is really key.
Yeah, well, I think, as you say, the big concern is that the NHS is going to show that actually they don't deliver anything of value, and then be applied to physiotherapy generally, both in both the public and private sector. So we've got a real opportunity here to show how we are different, and the fact that good quality care, individualized, personalized care, where we're using, you know, objective tools and things does actually really add value and has long-term benefit things. Because again, that's the thing with physio, is that the biggest benefit is in, you know, stopping people developing other comorbidities and keeping people active. You know, that's where value, especially to keep the health of the nation, lies. And I think we are really well set up to start to prove that with the work that, you know, that's ongoing within the whole MSKPN group.
No, I agree. And we certainly would not have, they wouldn't be so interested in us if we weren't doing all the simplicity stuff. I assure you on that. It's quite interesting. Fine. Do we have any more questions, or shall we call it a day? Great. Well, Claire, thank you very much. And to anyone who's listening to this, please, if you can let us know if you can participate, if you think you're in a position to participate in the work going forwards, please let us know who you are and what you're up to. Thank
Lucy,
you.
I just want to say thank you so much. You know, say you've really taken this and taken it to the next level and things, which is brilliant. And it's just great to have someone who is so passionate and engaged leading all of this for us now. And I really do appreciate that.
Thank you. Bye-bye.